Namaste everyone, welcome back to Drona Institute of Ayurvedic Studies. I'm Dr. Namita, and through this video, we plan to introduce a successful case report of a condition managed exclusively through Ayurveda. Let us take a look at the title, Conservative Management of Grade 4 Osteoarthritis with Internal Ayurvedic Medicines, a case report. It was published in the journal Annals of Ayurvedic Medicine, which is published by the Association of Ayurvedic Physicians of India, and it is a double-blinded, peer-reviewed, open-access journal. The article was published in the 13th volume and 3rd issue. This is a glimpse of the article. Here you can see the title, the authors, and the abstract. About the authors, the article was authored by Dr. Jiku Benny, Dr. Ashwati Kutivi, and Dr. Kuku Benny. Contents: Introduction, Case Presentation, Discussion and Conclusion. Introduction should basically cover the rationale, the background, what is the need of the study, etc. So here, the author has mentioned that osteoarthritis has a very high incidence worldwide and is a common joint disease in the elderly. It can also cause long-term physical disabilities, and OA of the knee joint contributes to nearly 80% of the total OA burden. Knee OA can be further classified using the Kellgren-Lawrence system, which is a radiological classification system on a scale from 1 to 4, where 2, 3 and 4 being mild, moderate and severe respectively. Non-operative treatments like drug therapy and exercise therapy are useful for patients with KL grades 1 and 2, which are the early stages, while advanced stages require surgical intervention like arthroplasty and osteotomy. Janu Sandhigata Vada is considered to be a close equivalent of KOA in Ayurveda. Stage-wise treatment protocols have been described for various musculoskeletal disorders, including Sandhigata Vada, in the text of Ayurveda. So here, the objective of this treatment is to minimize the pain, increase the range of motion, and reduce the disabilities in daily routine activities. Case presentation: a female patient who is a homemaker aged 68 years presented to the OPD with bilateral knee pain. The pain started 18 years ago and the patient consulted different medical systems with no significant improvement. When the complaints like pain, stiffness, giving away, and difficulty in walking without support aggravated, the patient approached the authors. The patient also had a history of hypothyroidism, which was controlled with homeopathic medications. There was no other significant medical or surgical history, and the patient was of moderate build. Clinical examination revealed swelling of bilateral knee joint, especially the suprapatellar pouch on inspection, and on palpation there was medial joint line tenderness, crepitus over the tibiofemoral joint, and the range of motion, knee flexion reduced in both knees and was restricted up to 90 degrees. The Western Ontario and McMaster University Osteoarthritis Index Score, which is a self-administered questionnaire consisting of 24 items basically about pain, and the patient had a score of 48 before the treatment. The timed up and go test, which is a measure of the stability of the joint mobility, was 47 seconds at the beginning of the treatment. Ideally, in an adult, it should be not greater than 12. If it is greater than 12, it indicates a risk of falling. It measures the static and dynamic balance. Now, numerical rating scale. It is a pain score and that was 8. Radiological and biochemical test. X-ray of bilateral knee relieved osteophyte formation, affected medial compartment, varus deformity, and significant decrease in the joint space between the bones, and there was nearly no cartilage remaining. All these findings suggested grade 4 OA. Laboratory test showed HB 10.6 gram per DL, while the WBC, TFT, KFT, LFT, ESR, CRP, etc. were within the normal limits. Differential diagnosis. So, what could be the diagnosis? There were many other confusing clinical diagnoses like rheumatoid arthritis, psoriatic arthritis, reactive arthritis, and gout. The clinical findings and the radiological evidence pointed to knee osteoarthritis, and the inflammatory markers, which were within normal limits, excluded the inflammatory conditions like rheumatoid arthritis, gout, etc. And there was the absence of the typical presentation of psoriatic arthritis, gout. So, these all led to the final conclusion of diagnosis as grade 4 KOA. Let us take a look at the dosha dosha. Here we can see that the patient had tenderness, morning stiffness, rest pain, and pain at night. Associated complaints also included occasional giddiness and a burning sensation in the chest. These symptoms suggested the diagnosis of a Vada Pittotara Vada Vyadhi, that is Pitta and Vada dominant Vada Vyadhi. Upashaya with initial Pitta Shamana Chigilsa also suggested Pitta Anubandhada. Here, Pitta dosha is causing Marga Rodha with its independent Kopahara Hedu. The X-ray findings also suggested grade 4 OA changes, and this demonstrates that Asti and Tarunasti Kshaya linked to Vada Vriddhi with Shleshika Khaba Kshaya. And the treatment was started. At the beginning of the treatment, the clinical presentation and the radiological evidence is an indication of total knee replacement. The patient was not willing to undergo TKR. The prognosis was explained and Ayurveda management was started. She was ready to follow the internal medicines with rehabilitation. Modern medicine, the patient was not continuing any internal medicine when she came for the consultation. And there were no allopathic medicine for pain and swelling as rescue medication. Treatment was planned in a stage-wise protocol. Initially, Pajanamrita quad was given in the morning and Dashamula quad along with Rasana Panchaka quad in the evening were administered. Tablet Kaishora Gugulu and Chandra Prabha, 1 tablet each, were added to the Kashaya. These medicines were prescribed for the first week, and when at the end of the first week, the pain was considerably improved, with the patient expressing pain score in NRS as 6. Then, for the next 2 weeks, rehabilitation phase 1, quad set drill and pillow squeeze exercise was added. The follow-up visit after 2 weeks relieved that NRS improved to a score of 4, and the time for tug test was also reduced to 16 seconds. And so phase 2 rehabilitation such as SLR and chair march was started. The internal medicines were also changed. Dashamula Kshira Kashaya was added as it was Brimhana and for pain management and operation of the joint. Kshira Kashaya was preferred as it could help with the intended pain management. And also to sustain the restoration of joint health, Rasayana was also needed. Kshira Bala Taila is mentioned in the context of Vada Rekta Adhikara, which describes both inflammatory and non-inflammatory, and it also has properties like Jivanam and Brimhanam, which could help with the restoration of joint health. Gandha Taila was given as a Rasayana medicine which can strengthen the bones and cartilage as evident from the classical description. 10 drops of Gandha Taila was given early morning for 2 months. And then rehabilitation exercises played a significant role in the management of this case. The exercises gradually increase the range of motion of the joints and improve the muscle strength surrounding the joints. It reduces the stress on the joint and subsequently prevents joint damage. It also responsible for the proper formation of subsequent dhadus like medas and asti. The assessment parameters noted were NRS pain score, which was before treatment 8, after the second week 4, and after 8 week 2. And the tug score before the treatment it was 47 seconds, after the second week 16 seconds, and after 8 week 12 seconds. The success of this therapy lies in the fact that even after 1 year of follow-up, the tug score was maintained at 12 seconds. The WOMAC score was 48 before treatment and 13 after 8 weeks of treatment. Here we have not gone for radiological findings because it is not possible to bring changes in grade 4 OA in the radiological aspect with pharmacological treatment. So the radiological measurements such as International D-Documentation Committee and KNL system are rarely utilized as outcome measures. Pain is a major symptom, and pain along with functional disability followed by radiographic severity are the most important determinant. So we have here gone for the pain relief as the main objective of the treatment protocol.
Hi friends, in this video we shall see a patient with grade 4 osteoarthritis covering a distance of 3 meter and returning to chair. The normal is below 10 seconds, but here this is grade 4 osteoarthritis and the patient is taking for a timed up and go test total 47 seconds in the initial visit. Initially, internally, we gave Amapajana Shofahara medicines. To that the patient well responded. The morning stiffness and rest pain reduced, and initially rehabilitation quartet and pillow skews was advised. In the second visit, you may see the difference in the tuck test, timed up and go test. The 47 seconds reduced to 16 seconds. In that phase, we changed the internal medicine, a transition phase, and again give SLR and chair massage to that particular patient. And in the last visit, you may see the timed up and go test, which is not normal, it is 12 seconds. We give internal sneha and standing weight bearing rehabilitation. And this case well responded to our management for osteoarthritis of grade 4. Thank you.
And thus, we have come to the conclusion that conservative management with Ayurveda internal medicine has provided remarkable improvement in the pain and functional mobility of the patient. An accurate diagnosis of the stages of the diseases with the help of thorough clinical examination and relevant investigations can direct to precise, stage-appropriate therapeutic measures in Ayurveda. The classical Ayurveda formulations have proven to be highly effective in addressing the severe stages of OA. However, to enhance the outcomes and optimize the efficiency, it is advisable to incorporate appropriate pathya and lifestyle modification which can ensure quick and cost-effective treatment solutions. I would like to thank the authors of this article for publishing your work and serving as motivation for the young clinicians out there to document and record their work as well. I would also like to thank all the viewers for patiently listening to this audio, and thank you once again.